to start their, I guess, Colby, you can start your video.
Great, thank you, Catherine, and thank you to eHI for putting together this wonderful event. It's very timely given today, of course, that the FDA is currently meeting regarding the decision to grant an EUA to the Pfizer vaccine. It's just an indication that while we do have a long winter ahead of us, there is some light at the end of the tunnel. But of course, we're just yesterday we saw the news that we had more deaths than what happened on 9/11. So while there is light at the end of the tunnel, we've got a long haul ahead of us in terms of the situation with COVID. And it's also a reminder of just what kind of situation we are in terms of healthcare delivery. What has been discussed here, I guess one of the benefits of, if you really want to call it that, it's kind of an oxymoron to say there's a benefit from COVID, but it's sort of thrust virtual care onto center stage. We had known what the research to date had said about virtual care, that it's highly beneficial in terms of expanding access to care, lowering admission rates and readmission rates, improving the quality of care. But now it's firmly ensconced in the discussion regarding access to care. And so we've seen an assortment of waivers, and we all know this from both the federal and the state level. The federal level, they've removed, temporarily speaking, the geographical restrictions. They've expanded the originating sites to include the patient's home. They've expanded distance sites to FQHCs. They've eased some of the enforcement discretion regarding HIPAA. They've removed the requirements for audio visual. And an assortment of other things. And they've also done some similar things down at the state level that are too numerous to mention by the 50 states, so I won't get into all of those. But one important aspect of all these changes is that they're juxtaposed to the public health emergency. And of course, what we know right now is that the lifespan of the PHE is uncertain. So we know that telehealth visits or virtual care visits have experienced an uptick during the COVID pandemic, but the uncertainty regarding the future of the reimbursement is kind of hanging in the balance right now. And so to kind of dig into these issues a little bit further and to provide some more context, I think we've really amassed here a very talented and renowned panel of experts here. And I know Peter has not joined us here, so I'll go right into the introductions. Our first panelist.
I'm here, Colby.
Oh, yes, Dr. Antel.
Yes.
So I'll get right into your introduction. So thank you. Dr. Peter Antel is the Chief Medical Officer at Amwell, where he is responsible for the clinical direction of the platform, as well as clinical guidance and training for all of Amwell's clients. He is also the founder and president of the Amwell Medical Group, the nation's first national telehealth medical group. In this role, he manages thousands of clinicians in a variety of disciplines, providing telehealth services in all 50 states. Dr. Antel has developed innovative programs to measure and ensure quality in telehealth, developed a national telehealth credentialing program, and has played an active role in national efforts to modernize telehealth laws and regulations. Dr. Antel has a track record of disruptive innovation in the areas of care delivery, medical management, business development, technology, and telehealth. He has built and managed medical practices, founded a hospitalist company, written software for mobile apps and phone-based triage, and has been actively building telehealth programs since 2009. Dr. Antel received his MD from George Washington University in 1995. He completed his pediatric residency at Rainbow Babies and Children's Hospital, in addition to a year fellowship in hematology oncology at Stanford University. He is board certified by the American Board of Pediatrics and practiced general pediatrics from 1999 to 2015. Our second panelist, Jenny Whitman, is a public policy associate at the Alliance for Community Health Plans. She is responsible for leading the ACHP Health Data Innovation Work Group and ACHP Telehealth Policy. Jenny also offers policy review and analysis on topics including Medicare Advantage, the individual market, price transparency, supporting ACHP advocacy efforts. She previously worked in clinical fields ranging from ENT to researcher before coming to ACHP. Jenny holds a BS from Rhodes College and an MS from Georgetown University. And rounding out the panel will be Lauren Konaboy. She is the Vice President of National Policy at Centerstone, a not-for-profit health system specializing in mental health and substance use disorder treatments. As Vice President of National Policy, Congressional works to advance policy and regulatory initiatives to accelerate access to affordable, patient-centered behavioral health services that are rooted in the best science of care. Through her advocacy, Convoy has directly influenced the passage of several bills, including passing legislation to create the nation's first ever 3-digit dial-in code for suicide prevention, as well as directly influenced several provisions of the 2018 Support Act, a bill designed to combat the nation's opioid crisis. Prior to joining the Centerstone team, Convoy worked as the Government Affairs Director for 7 county services in Kentucky, where she advanced policies to increase access to addiction treatment services, engaged in the state's 1115 waiver process, and co-chaired a committee that modernized the state's telehealth regulations for Medicaid. In addition to over a decade of experience running state and national public policy and advocacy campaigns, Convoy has also worked in the clinical realm as a marriage and family therapist. In 2019, Convoy was recognized by Business Insider as a top DC health policy power player. Convoy graduated from the University of Louisville with dual master's degrees in clinical social work and marriage and family therapy, and from the University of Wisconsin-Stevens Point with a bachelor's degree in political science. With that, the introductions are complete, and I'll turn it over to Dr. Antel to go ahead and give his presentation. Dr. Antel?
Great, thanks, Colby. So I'm gonna go very quickly, so strap yourself in. I wanna make sure we have time for Q&A. I'm gonna talk a little bit about Amwell as a company and what our viewpoint is on telehealth in general, where we are, what we're doing. And I would, if you could advance through, there's unfortunately a couple animations on this one. Yeah, one more. Then I'm going to talk about the impact of COVID and what we saw in the telehealth world, and finally I'll go on to our our regulatory priorities, regulatory and legislative priorities. Amwell, we are a technology provider, so we provide white-labeled software for various entities to use to aid in the provision of consumer-facing telehealth, hospital-based telehealth, and a number of other sort of different use cases. We work with health plans, health systems. We work with other innovative companies, Google and Apple and Medtronic and others. Next slide. A little bit about our client base is, you know, we're really quietly sort of, we like to think of ourselves as sort of the Intel inside when it comes to telehealth. We're there powering programs from health plans, employers, health systems, as I mentioned, technology companies, and even a bit in the retail and wellness space. If we go to the next slide, even in our world of telehealth, there are so many different variations. There's so many different models. You know, classically, our legacy software supported the sort of the on-demand, on any device, consumer-facing devices type telehealth, as you see on the left. That was often things like urgent care, but we've moved into more behavioral health and even more chronic disease. Follow-up care, so arming providers to use telehealth as a tool to see their own patients. And then you get in, and that's generally in the outpatient setting. Then you get into the subacute and the inpatient setting. Our acquisition of Avizia a few years back armed us with a whole new area of value in the fixed endpoints, the carts that are rolling around in emergency departments and other places. Next slide. The Amwell Medical Group, this is a separate medical corporation, in fact, a basket of professional corporations that provides 50-state coverage. Not surprisingly, when we work with health plans, they do want to leverage a group like ours to help support their members. But somewhat surprisingly, even the hospital systems themselves and those that have providers working for them often choose to use our Amwell Medical Group. So we have a large national group, as you can see in the center of the slide. Primarily, you know, largest group of providers are physicians. We do have our second largest group is therapists, where we just can't find enough therapists these days with the amount of behavioral health challenges going on. A little bit of psychiatry, and then other lactation consultants, care managers, dietitians, and a few other areas of specialty. And we support a lot of programs. Not only do we provide standard care, but we support EAP programs, we support risk assessments and sleep medicine, even some disease management and RPM offerings. Next slide. So this was the view from 2017. And this was Eric Topol. I'm sure most people are aware of Dr. Topol. He's a well-known futurist. And he predicted back then in 2017 that by 2024, we'd reach the crossover point where an equal number of healthcare visits would be done virtually as compared to in person. What COVID did was advance this curve substantially. Now, we're not quite at the crossover point, but we're a lot closer than we thought we'd be in the year 2020. Next slide. So speaking of 2020, I don't need to tell anybody on this call, this has been a year of adapting and adopting and change and frustration, and we all have gotten a little too used to using video conferencing. But it's been a big year for telehealth. This is the year that telehealth really went fully mainstream and became an essential part of how healthcare is being delivered. If we go to the next slide, I'll show a little bit about what that means. The line with the numbers represents the number of COVID cases. These are the first two waves, the April wave and the wave in the summer. So this goes through August, so it doesn't show the current wave. And the bars there represent the percentage of overall healthcare visits being done or that were done virtually. And as you can see, we hit back in April a peak of 52%. So over half of all outpatient clinical visits were being done through telehealth, a pretty remarkable number. And look how quickly that change happened. That happened in a matter of 3 to 4 weeks. So it really was a remarkable time. It was an all hands on deck moment. We had our hosting people, I don't think, slept for about 2 months because you're not really ready. You don't prepare to scale up over 9x your normal volume in a matter of weeks. It really was a remarkable time. Next slide. So, what did that mean, with regard to provider and patient adoption? We do a survey every year. So this was a really helpful time to take a look at what did this mean. So in 2019, only 8% of consumers surveyed had ever had a video visit. In this year, that number jumped pretty dramatically up to 22%. If we go to the next slide, on the provider side, it was even more dramatic. In 2019, 22% of providers claimed they had done a video visit before. That number jumped to 80%. So a massive increase in the year 2020. And if we go to one more slide, I'll show you a little bit about what that looked like in our world. The purple line represents essentially our Amwell Medical Group and primarily urgent care volume. And that volume spiked 700%, 7 times in a period of weeks. And that represented the period of time in April when essentially most of ambulatory medicine closed down. They didn't, or they restricted their care to only healthy people. If you see the other line, the growth in scheduled visits, which is primarily non-Amwell Medical Group providers, external providers, that growth had been slow but steady over the years. But look what a difference occurred. It took a little bit longer to materialize. These providers had to get onboarded and trained, but those visits on our platforms went up by 50 times during the summer of this year. It was really, really a remarkable change. Now these numbers are settling back in. Offices are adapting, they're adjusting and seeing patients again in person, but those numbers are tending to be in the sort of 18 to 20% range at most healthcare systems these days. So still a substantial percentage of care is happening via telehealth. And if we go to the next slide, in the interest of time, I'm going to really jump over this. Essentially what we did, we had to adapt pretty dramatically during this whole year. And so we grew our existing network capacity of providers. We recruited new providers in a pretty dramatic way, and we streamlined our onboarding and support. We can onboard providers really rapidly and even get them credentialed rapidly within days, meeting NCQA standards. So a lot was done to be able to meet this crushing demand. In terms of regulatory changes, we all know, I'm no lawyer or a lobbyist. Most on the call probably know as much about this as I do or more. But obviously a lot of changes at the federal level, reimbursement, HIPAA, DEA. A lot of changes at the state level, Medicaid rules and reimbursement, licensure reciprocity, and loosening of restrictions on modality requiring video or even requiring synchronous care. If we go to the next slide, what we believe, or maybe I should have said what we hope, is that some of these changes will persist. Hopefully, things like the Medicare site and geographic restriction, we have our fingers crossed that that persists, and we're doing a lot of work in Washington to try to move that along. Some of the some of these will lead to change. DEA has been asked by Congress for a while now to promulgate new rules regarding controlled substances and telehealth. And then we expect some will revert back, like HIPAA, waivers on HIPAA compliance. Obviously, most on this call know HHS and CMS still have their concerns about fraud, waste, and abuse. And the CBO in Congress is still worried about cost and overutilization. So these are the hurdles we have to overcome. And next slide, and I can end on this slide rather than the final one. Our priorities, reimbursement, many areas, Medicare fee-for-service being the most important to us. Medicaid, having consistent reimbursement policies around the country would be very helpful, and more permissive policies. On the commercial side, fair and consistent reimbursement and transparency. Health plans, in my experience, don't seem to even like to post their rules or their guidance on what's reimbursable and how to submit claims. Licensure, we're focused on a true national compact. The FSMB compact has been an incremental improvement. But we're interested in things like mutual recognition or medical excellence zones. At the DEA, we'd like to see modern rules that either help with our opioid problem, our opioid epidemic, and allow substance use disorder treatment, or alternatively, if the DEA were to promulgate rules on non-opioid controlled substances so that psychiatrists could use Xanax and stimulants and other controlled medications with a proper telehealth-based evaluation. And finally, we're interested in broadband equity. We don't think it's fair or proper that people that happen to live in a more rural region may not have access to this kind of care. They may already have access challenges given their rural location. We'd like to see them be able to access telehealth to get the care they need. And we can go to my final slide, but I'll end there. The toothpaste is out of the tube. I won't walk through any of these details, but telehealth is here to stay, established part of healthcare, and we're excited about the future.
Thank you so much, Dr. Antel. Excellent presentation. So we're moving on to our second panelist, Jenny Whitman. Jenny.
Thanks so much. And I just have to say, Dr. Antel, you teed up my remarks almost perfectly, so I appreciate that. I'm just going to stay on this slide for a second here and just do a quick overview of ACHP as an organization. So we are a nonprofit trade association representing 25 not-for-profit health plans that are community-based health plans, meaning they have really deep roots within their local communities or their regions. In addition, every ACHP member holds true the payer-provider aligned model. And what we mean by that is each health plan has a really close connection with their provider system or provider arm, whether that be fully integrated with a provider arm or, as I said earlier, the close community-based relationships. So we cover 35 states, including the District of Columbia, and in all lines of business as well. I'm going to dig into what I think are the really interesting aspects of ACHP member policies right now. Thank you so much. The reimbursement model that we just developed for telehealth payment past the COVID-19 pandemic. I'm going to take a step back here for just a second and go into a little bit how we got to this point. So early on in the pandemic, we surveyed all of our member plans to get a better assessment of what telehealth priorities might look like for them in the next few months and throughout the pandemic. And one of those questions was about the regulation on payment parity. And we got a mixture of responses back, pretty understandably, given the nature of our ACHP member plan organization makeup. And we quickly realized that this payment parity conversation was a little bit too narrow in scope, and we needed to take a broader step back and take a big picture look at how we're going to think about telehealth reimbursement, not just within the pandemic, but for a long-term and sustainable future. I'll also just quickly note that out of that came a number of these shared sort of advocacy priorities that Dr. Antal already mentioned. So I'm not going to go into all of those. I think everyone here is probably pretty familiar with almost everybody in the industry is advocating for right now in terms of telehealth permanency. We are not exempt from that. We are very much excited about telehealth becoming a permanent part of care delivery models and for health plans as well. But as Dr. Antal noted just at the end there are still significant concerns about telehealth increasing costs and utilization and its potential to open doors for fraud, waste, and abuse. And ACHP felt like a good way to address some of those things was to take a closer look at Medicare fee-for-service reimbursement for telehealth services. And we decided we wanted to, as you can see on the slide here, come up with a solution that would illustrate a financially sustainable path for telehealth past the public health emergency, so that telehealth payment is aligned with high quality care and is out of the fee-for-service incentives that highlight volume of services over value of services typically. And then that would guarantee patients, providers, and payers to maintain highly coordinated, convenient care. Next slide, please. Perfect. So I know there's a lot on the screen here. So again, some of the other barriers that we noted, in addition to the concerns over fraud, waste, and abuse and telehealth's potential to increase costs and utilization, as I noted, are the fee-for-service incentives for volume over value, and then also the insufficient infrastructure around telehealth. For example, we had a number of ACHP member plans prior to the pandemic who didn't offer telehealth services. It just wasn't something that their community and their local populations were asking for, or that, felt that they needed. However, when the pandemic started, those plans implemented full-on telehealth services within a matter of weeks, which is just an enormous undertaking, as you can imagine. So ACHP, again, saw all of these barriers and really felt like the only way to address those things was to offer something that was value-based, that we could take to Capitol Hill, take to the administration and say, this is addressing a lot of your concerns. In addition, this is an opportunity for Medicare to be, once again, the leader in terms of reimbursement and payment policy. And that led us to this white paper, which if you go to the next slide, this covers some of the assumptions that we made in the white paper. We offered two models, both a little bit different. One, as you can see here, is called support and reform, and the other is prove and grow. But both of these have a couple key assumptions. I think the most important one to highlight is that something like this takes time to implement. And so what we wanted to do is offer a 5-year transition period for data collection, stability, post-pandemic recovery, and most importantly, in this 5-year period, we would ask that providers continue to receive payment parity as they had throughout the public health emergency. We felt that was really essential to get to the point that I had just mentioned about necessary investments in infrastructure. A lot of some of the smaller provider groups or smaller health plans that are going to be implementing the systems, or potentially, making significant changes and modifications to ensure that their IT infrastructure is sustainable, not just throughout a pandemic, but in a long-term fashion. So we felt that this payment parity was going to be key in order for providers to be able to make those sorts of initial investments for maintenance and updates and new technology. The other things that we assumed were that this was going to rely on certain other aspects of the telehealth flexibilities being made permanent, such as eliminating the site of service restrictions and allowing expanded provider types to continue offering telehealth services, as well as non-provider types. And the support and reform framework, by the way, I should just pause and say that if you are at all interested in this white paper, it is on ACHP's website. And I encourage you all to go check it out and email me if you have any questions or just want to have a further conversation about it. But support and reform is really interesting because it sets a premise saying that telehealth services are going to be reimbursable across all provider specialty types. And this is an opportunity for us as an industry to make a big investment in telehealth that is, as I said, value-based, affordable, with an intense focus on quality of services. So there's a lot of that quality measurement and evaluation built into the model. The prove and grow is a little bit different. We took a more simplistic stance with this one, where we said, well, why don't we try telehealth services at a higher reimbursement rate for primary care type providers, such as behavioral health, PCPs, family docs, and then see how that works in an interim, and then potentially, as the title would imply, grow. And so, again, I know I'm a little bit short on time here, so I'll just stop there for a minute and say that our ultimate goal is really to take this. It's not perfect, it's not final in any way. We're hosting a roundtable discussion where we've invited a number of stakeholders to help engage with us on this topic so that we can impose a value-based framework on top of Medicare fee-for-service, recognizing that this is still an essential component to provider reimbursement long-term, and it's going to be with us for a little while. So we want to make sure that we use the tools that we have and offer additional tools for providers that want to be moving towards value over volume. With that, I will pass it on to the next panelist. Thank you.
Thank you very much, Jenny, very informative. As we get into our third presentation, I'd like to go ahead and remind folks that we will have a Q&A right afterwards, so please start to go ahead and formulate your questions and to type them into the Q&A box. With that, with our third presentation is Lauren Konaboy. Lauren?
Yes, hi there, thank you. And I think I'll echo a lot of the sentiments that the other two panelists presented with regard to policy, but talk a little bit more about our experience as a behavioral health provider in this new environment. You can go to the next slide. So Centerstone is one of the nation's largest not-for-profit providers of behavioral health services. We offer the full continuum of care from inpatient to outpatient services. We have a military services footprint throughout the nation, and we have a Centerstone Research Institute. And the Research Institute embedded within our company looks at evaluation, clinical pathways, and adherence to evidence-based protocols within our clinical pathways. Next slide. So like many providers, before the public health emergency, before March 2020, a small amount of our services were delivered via telehealth. And so for us, under 7% of our services were delivered via telehealth. And even less so for our substance use disorder services. Our medication-assisted treatment delivery, under 3% of that was done via telehealth. And then of the majority of our 3,500 staff, they worked in brick and mortar buildings before March 2020. Next slide. Then as we know, COVID hit, and on March 13th, and something that we're all thankful for and what has been expressed is that we would like these emergency telehealth waivers to be continued. But March 13th is when these emergency telehealth waivers were activated. And our telehealth utilization went through the roof. This shows kind of rolling monthly averages, but within the first couple of weeks, we were hitting 90%. And so to jump from 7% telehealth utilization to 90% in a really short period of time, was quite the feat. Moving 3,500 staff home, changing that model, all of that. And something that, we continue to hear that providers around the nation were able to accomplish this. And something that I've heard US senators comment on, we've been talking about telehealth for 20 years, and we did more with telehealth in the first 3 months of the COVID pandemic than we did in 20 years. So, truly amazing in terms of the care delivery and the ability for providers to pivot and meet the needs of consumers and deliver care when and where they needed it most. Next slide. So as many of you might be aware, with the telehealth emergency waivers, there are a myriad of provisions that are allowed, and one of them is the provision of audio-only services. A lot of our footprint is in rural areas around the country, and we also serve a large percentage of Medicaid safety net patients and consumers with higher acuity behavioral health and comorbid conditions. And so there's a decent percentage of our client population that either does not have access to a smartphone with audiovisual technology, or lives in a rural area with no broadband internet and can't access that audiovisual technology. So this is just a pilot that we did in Tennessee. We started out really heavily relying on telephone and the audio-only provision to engage our consumers. And one of the things that we've been piloting in Tennessee is, addressing the question of how do we drive that audio-only number down. We believe that we still need it. We believe that there's consumers that just will not be able to get that service without audio only. But what would it look like? What could we kind of throw out this problem to have those encounters be converted to audio-visual encounters? And so through our pilot in Tennessee, and I should mention that these, what we've done does not have a direct reimbursement mechanism. It's been done through our own operation expenses and or other federal grants that we have. But what we've done is a pilot on a couple of fronts. For consumers with audio-only technology, we opened telehealth rooms so that they could come into the office, be in a telehealth room, but meet with their provider, whether the provider was in the same building but in a different room, or on the other side of the state or a different state. But they could come in to those telehealth rooms. Another thing that we've piloted is for consumers that have transportation barriers. If a case manager goes to their house, drops off a tablet, they have that tablet inside their house and they meet with their psychiatrist that way. It's a way we've been able to kind of have that direct-to-consumer interface. And so we've really gotten creative with that and have driven the number of audio-only encounters down in this pilot. But and this pilot, again, is from Tennessee. But we have found it's also very resource intensive. So it's something that we're still looking at. And in the meantime, I think we continue to be thankful of the flexibilities that exist and cognizant that multiple tools in the toolbox are necessary to give consumers what they need. Next slide. So I mentioned this a little bit, but shortly after that March 13th date, when the telehealth waivers were enacted, we saw our overall weekly averages soar up to 90%, for a little bit of 90% of our services being delivered via telehealth. And today, fast forward, we've opened up a lot more of our offices, but we still are doing the majority of our services via telehealth, even with significant reopenings. And so we've kind of stayed pretty steady around the 60% marker for the past couple of months. And that was even before we were experiencing our recent surge in COVID numbers. And if you remember in one of my earlier slides, I mentioned that under 3% of our services for medication-assisted treatment, that's for substance use disorder, prior to the pandemic, under 3% were delivered via telehealth. Today, over 45%, so nearly 50% are delivered via telehealth. And I'll give one example in Illinois. A lot of our services in Illinois are in downstate, so really rural parts of the state. And most of our psychiatrists are based out of Chicago. And so prior to the pandemic, because of some of the provisions that exist, especially that initial, before prescribing a controlled substance, that to establish that relationship that the patient and provider would have to meet in person for that initial encounter, our psychiatrists would have to drive down from Chicago to the southern tip of Illinois to meet with patients. And you think of, being in a workforce shortage, being in, what we've now been in for a couple of years, an opiate crisis, that that's not the best utilization of workforce, and it's not the best way to meet the consumer's needs either. And so that's something we continue to really rely upon. And also from a clinical outcomes perspective, so far our clinical outcomes have shown that for the treatment of depression, our outcomes have been the same as they are for in-person. For the treatment of substance use disorder, our outcomes have actually been slightly better with telehealth than they are with in-person. And so with the delivery of medication-assisted treatment, those patients are still receiving that full continuum of care. They're just receiving it virtual. So they're still meeting with their therapists, they're still doing groups, all that stuff. And we're seeing really, really promising outcomes. And then last of all, of course, our over 3,500 employees are now working primarily in a remote work environment. So next slide. So what's our utilization like today? This is a quick snapshot from November and a couple of days in December. And the utilization for this month is lower because, of course, we had the elections, we had Veterans Day, we had Thanksgiving, but just wanted to highlight. So in yellow are our telephone, so audio only encounters. In kind of that red pinkish color are televideo, so audio and visual. And in green is televideo or telephone. And the reason we have the or in there is because something we're still working on is with our own EHR and workflows, appropriately accounting for which goes into which. And also one of the things that we asked for in our physician fee schedule was there to be a modifier or some other coding that would really, really identify what was an audio only service delivery so that it was more unified across our systems. Next slide. So big picture, what have we seen over the past few months? So as many of you may be aware, back in August, the CDC came out with an alarming report that 1 in 4 young adults had recently reported contemplating suicide. And the data that we've seen in our own system tracks with that. We've seen a 44% increase in call volume over the past couple of months. The biggest increase is presentations for severe anxiety, depression, suicidal ideation, and substance use disorder. We know that over 40 states have reported increases in opiate overdoses. And so we are already seeing this pretty significant rise in demand for behavioral health services. Another kind of complex part of the data is that usually the peak for behavioral health needs kind of comes 1 to 2 years after a disaster ends. So we suspect that we haven't hit the peak of this and that we're still walking into it, which is, of course, worrisome knowing that there's workforce shortages. And on the workforce end, we've probably seen a lot of the reporting that there's an increasing number of women leaving the workforce. And the behavioral health workforce is predominantly women. We've seen that in our own system of licensed therapists, licensed credentialed therapists, leaving the workforce to help their children with virtual learning, stay at home, all those things. And so our workforce, we're seeing the kind of the workforce shortages become even more intense within our system as the demand grows. And then the last kind of complicating factor here is that Medicaid programs and some commercial payers around the nation are looking at telehealth rate cuts. And so we see this kind of compounding variable of potential rate cuts along with this workforce shortage and this really, really stark increase in demand for services. And so just to kind of end there is that it may be too early to determine, but it seems that these could be some of the early markers of a behavioral health access crisis, and that we'll continue to need all the tools that we have at our disposal to meet consumers where they're at and provide life-saving services. And telehealth and the flexibilities associated with that are a big part of that game-changing package. So with that, I'll conclude my remarks.
Thank you very much, Lauren. And I think I speak for everybody in regards to our 3 panelists for giving a great overview of what the current environment is and where we can expect to go in terms of telehealth. So this commences, gives us the opportunity to commence with the Q&A, and a couple of questions have already been typed into the box here, and they touch on some of the primo issues that are first and foremost on our minds regarding where we are with telehealth and where we need to go. Steve Waldron, for example, he has a couple of questions here, so I'm going to go ahead and parse these out and then throw them out to the panel as a whole. We can't compare telehealth use prior to COVID with what's being done currently in the COVID environment. So he asked, how can existing evidence on cost be applied to post-COVID telehealth? And obviously, I think this gets into the CBO conversation. Some of you, all of you know, that the CBO relies heavily on the theory that, with the more visits, that means costs are going to increase. So what do you all think about that? How can existing evidence on cost be used in a post-COVID environment in terms of telehealth?
I think it's a great question, and I'm going to go ahead and just because my presentation was all about reimbursement. That is such a key point, and that's one of the things that we identified really early on at ACHP, particularly because, as I noted, we had some plans going from zero telehealth services pre-pandemic to offering almost 100% of services via telehealth during the pandemic, and they did so in a matter of weeks. So I think no matter what data you look at in terms of cost data, it's going to be skewed. You can't look at pre-COVID data to get a good idea of what it's going to look like past the pandemic, and you can't look at pandemic data to establish what it's going to look like past the pandemic. There has to be a period of time afterwards where we really take a moment to say, okay, this is likely what things are going to look like for the next few years. And I think we still really won't know that potentially even a year after the pandemic concludes. And when I say the pandemic concludes, I really mean that we're out of this sort of emergency crisis mode. I think there's going to be a lot of lingering effects. I don't think it's just going to be on day zero, everything's back to normal. That's just not realistic. But I think there's going to be a moment in time where we have to take a good look at all of the trends throughout the past 9 months or wherever we end up at this rate to establish what cost is truly going to look like. So I'll stop there and let the other panelists chime in.
I would just add a couple things. I think our viewpoint is that this is not a new specialty. This is not a different, essentially a totally different form of care. This is a different, clinical site. And, the more we see, we believe the more we see providers using telehealth as a tool to engage with their own known patient panel, and that we remove restrictions on reimbursement, restrictions on geography, restrictions on modality, we'll see innovation. And so I think if you want to see innovation now, I would look to the closed systems like Kaiser and see Kaiser's utilizing telehealth as much as anyone in the country, not because it's sexy or the next cool thing, but because they see value, and they have a budget, and they're a truly integrated system. So I would look to organizations like those. There's research out there about less utilization of labs and radiology in a telehealth environment. A lot, of course, depends on the use case, but I think if you allow for the arbitrary restrictions to go away and you allow for innovation to occur, our hope is that we see improved outcomes and decreased cost.
I think another thing that we can expect to see too is a better understanding of where telehealth makes sense within different specialties and different sectors of the healthcare industry. I don't think it's going to be the case that we see high telehealth utilization for specific specialties like gastroenterology versus behavioral health, as I think Lauren would agree from everything that she's seen over the last few months. So I think that'll be really key in terms of understanding what are the cost saving potential for telehealth and what's the actual value and outcomes that is associated with that.
Lauren, I saw you shaking your head there. What is your perspective?
Yeah, well, and I didn't jump in because I thought that Virginia and Dr. Antal captured it really well. And I'm thinking about also from the policy angle. So we do a lot of work on Capitol Hill now virtually. And the CBO scoring, the challenge with CBO scoring is that it's typically not dynamic. It's not looking at offsets that you're getting from people not going to the ER because they had that suicide intervention service right when they needed it. And that's the type of data that over the next year or 2 years we'll have more and more of, and even through obviously the time now, the almost 9 months of the pandemic public health emergency. And so I think the more that we have that data, and that CBO isn't going to have to model that, but we can actually say, here is the cost, quality, and outcomes, we'll make the case. One complicating factor is that many payers are reporting that utilization is way down, and so there's obviously the question of, is it going to spike because people are deterring getting certain treatments because they want to avoid exposure and because of all the other parameters that have existed. And so I think we're going to have to wait a little bit to see whether or not we see that spike. But certainly from our perspective, and we on the behavioral health end, kind of that value-based work is where we're driving. We are always looking at the intersection of how do we achieve quality with the services that we're delivering. And if anything, this massive experiment, will give us a lot more data to look at.
And I might just add one more thing, and we're really thinking about changing the way healthcare is delivered. And it's not just about the live visit. The live visits are needed and important, but so much of outcomes is determined by what that patient does between visits. So if you think about diabetes, did they fill their medication? Are they testing their glucoses? Are they adhering to their diet? All of those things matter. And the more we can marry asynchronous touch points with patients, chatbots, nudges, to encourage compliance, the more potential we have to make inroads in terms of things like diabetes and the worsening diabetes epidemic that we have in this country.
And Dr. Antal, you get into Steve's secondary question here. It's kind of an extension also of the evidence generation, but he's talking about particularly how virtual care has become such a huge umbrella for digital health, telehealth, mobile health, RPM, artificial intelligence. How do we adequately parse out all the different subsidiaries of virtual health in terms of evidence generation, and what segments should be prioritized over others?
Boy, do we have another hour or two? That's a meaty question.
So can I give an example? CMS, for example, and everybody knows this, parses out remote patient monitoring from telehealth. One is asynchronous as opposed to one being in real time.
It's very difficult in a fee-for-service environment to parse those out, honestly. It works so much better, and that's why I think many of us are advocating for more value-based care, more integrated care, because in that environment, you can lean on providers to begin to do what makes the best sense for the patient. All of these are different, but all of these can commingle. So we're working, for example, we're doing virtual primary care right now, where we're really trying to bridge the gap between how traditional care would happen for, again, to use diabetes as an example, versus what would be done in a disease management program for diabetes. And we're merging those together. So what does that mean? That means a device in the home that's connected. That means nudges to make sure the patient is on program. That means escalation paths and triage paths, putting all of that together to blur the lines between traditional care and more sort of modern approaches to disease management or population health. It's not easy. It's going to take time. Different organizations are going to approach these things very differently, but we now have a whole sort of a menu of tools that we can begin to apply and try to figure out how we meld those together for the ultimate purpose of improving outcomes.
So in the interest of time, I'm going to go ahead to the second question here, and this gets into another major issue regarding the increase in telehealth. I've written on this before, and it's easiest for us to assume that with the increase in the procurement of telehealth visits, that it's increased access to care for everybody. But the truth is that with any new healthcare protocol, it also has a liability to exacerbate existing disparities in access to healthcare. And Linda Rowe asked a very poignant question here. I'm curious as to how to handle telephonic visits. I'm the chair of the board of an FQHC, and there are some patients who don't have the technology to engage in telehealth, but are willing to do telephonic visits. How does that get reimbursed, and how do you handle that in the long term, given that access to care is a key barrier in this population? And so obviously this gets into the audiovisual requirement that's been removed, but it also gets into broadband access. So Lauren, why don't you go ahead and start us off?
Yeah, sure. As I mentioned earlier, we've been doing a lot of work around this, and from our perspective, kind of the clinical gold star for telehealth engagement is audiovisual, but we realize that there are a large percentage of our consumers that cannot get that, and so in that instance, that's where the audio only component has really been a game changer. There's something else here that's kind of coming down the pipeline, but that is that Congress and the FCC this year passed legislation and regulatory authority to establish the nation's first ever 3-digit dialing code for suicide prevention, 988, that will go into effect July 2022. And this conversation is also very pertinent, just kind of planning for how do we continue to provide behavioral health services in an equitable way around the country. And as you map out the country and what population has access to things like the audiovisual components and broadband internet, it's something that we're not going to solve overnight. We're not going to solve it in a couple of years. It's a long haul problem. We need to start investing in broadband infrastructure, but we need to continue that. And in the interim, audio offers a really good bridge to provide services. And so, I understand there'll be continued conversations around how do you ensure clinical quality, protect against fraud, all of that with audio only. And I think that we can address that through integrating telehealth platforms into EHRs and documentation and other parameters and guardrails. But in the interim, audio only is going to continue to be a really critical linchpin for bridging that digital divide.
Jenny, what is your perspective?
Yeah, I think I completely agree with Lauren on the integrating a lot of the EHR components. I think we're going to see a lot of significant improvements given the interoperability compliance deadlines that are looming large. So I think there's going to be a lot of health plans making modifications to improve upon a lot of those software technology sorts of things. But I think at the end of the day, it still is going to come back to reimbursement, right? People are going to need to be reimbursed for audio only services. And I think there's going to be unwillingness to have that conversation without other guardrails in place. And so, one of the things that we've been thinking through in the development of our white paper and these reimbursement models is, well, how do you establish whether or not something is effective or appropriate to provide services via telehealth? And that includes some of the asynchronous technologies we were talking about, but also audio only services, and then also the video component. And so I think you really have to take a good look, almost specialty by specialty, to establish what makes sense, what's effective. And if it's not effective, then okay, you really need to say that this should be an in-person only service. But I think once you start parsing some of those things out, the audio only reimbursement conversation becomes a little bit more feasible. And at the end of the day, folks on Capitol Hill and in the administration are going to be more willing to have those conversations with you if you say that, as opposed to just saying we need audio only permissions for all services, because I think it's going to be a really hard conversation to have with anybody.
Dr. Antel, what about you?
Yeah, a couple things. Certainly audio only is a different level of care for most specialties. One might argue, gets close to video, true synchronous audio video level of quality in a talk only specialty like therapy maybe. Even there you don't see body language as much, but it's closer. I think there's two things. I think number one, some of those involved in making policy, I think they have it a little bit off. And what I mean by that is today all providers are used to the notion of justifying your care met the criteria for a CPT code, and that you document properly to make sure that it's clear and you're eligible to be audited on that documentation. I think that my perspective is we should be using that kind of methodology, not making generic statements that this specialty should never use audio only and this specialty should. Not that that's a terrible idea. I understand that there may need to be some looking at that, but really about justifying, did your care meet certain criteria in order to submit a reimbursable code? I think might be the way forward. The other thing I would say is there are a number of entities, and I've spoken with NCQA and URAC, for example, that are looking at accreditations. The ATA has an accreditation. I think we could also look at accreditations as a way forward if the accreditation does a good job of evaluating things like, for example, do you make a good faith effort to try to have a video visit? Are your providers trained in what is appropriate and what isn't appropriate, the guardrails around audio only? Are they trained to properly refer for a video visit or for in-person care if you can't meet evidence-based standards? You know, these are, I think, areas that we could create some sense of safety here and mitigate some of the concerns about fraud, waste, and abuse.
I just chime in for one quick second here and just say that I completely agree with what you just said. And the reimbursement model we proposed does actually include a lot of those components that you were just talking about. And it's not so much that it's this specialty can do that or that specialty can do that. I don't think that's the right way to go about it. It truly is looking at virtual care and where it's effective. And you establish that effectiveness based on quality measures, outcomes, and things of that nature. And a lot of this data that I think is going to be so key in the next few years as we really try to wrap our heads around what happened in the pandemic, how was telehealth used, how is it essential, because I don't think there's any argument that it wasn't essential. And so building upon all of that to make sure that we can have audio-only services for the places that it's necessary.
Makes sense.
As I say, one thing as I'm listening to this, I think the tricky part there is that Congress and CMS navigates things as either in or out rather than guided by clinical best practice and expertise. And so I think that's where we're going to see, you know, how does Congress and CMS ultimately thread the needle there and create some level of flexibility for letting clinical expertise and best practice lead while also determining what's in versus out if they do that.
It's a great point. I also think, and sorry, I could talk about this all day, obviously. I think it's also really important to that point exactly is that telehealth, we don't fully understand all of the range that is possible with telehealth and virtual care. I should really just say virtual care. And all that we know about it right now is going to change. There's continues to be innovation. This is not a fixed system. It will continue to grow and change and improve and be modified. And so I think we have to be careful too when we're advocating for policies and legislation that we're not too prescriptive, because I think we don't want to get ourselves in a situation where in 5 years, what we thought would be perfect for now is actually not applicable anymore because the technology and the industry at large has changed so much in that time and space.
Most definitely, and agree with you. And I think we're also running the risk of getting into the technological literacy argument too. The faster the technology evolves, I think the potential for we're leaving more and more behind, not in terms of access to it, but being able to use it. So in the interest of time, we have one final question from the Q&A box, and this is actually targeted specifically at Lauren. This is from Howard Rosen. Regarding behavioral health issues and the potential for access, which he agrees that in the long term, we'll result from COVID. The question is, what telehealth solutions are being explored within the realm of mental health and behavioral health currently?
And by telehealth solutions, Colby, can you expand upon your interpretation of that other than as it's stated?
I'm presuming that he means what telehealth modalities are being explored. Okay.
So, I mean, primarily video audio, this modality is what we're using. And so we are piloting a few different options there. I mean, the list can go on of what's possible and what's new in tech, everything from apps to manage care in between services, the introduction of AI into management. But for the most part, we're conducting our clinical pathway almost as it was in person, but kind of adapting it to this virtual modality with both audio and visual. You know, some of the things that we've been looking at is how do we do things like patient screeners. Usually when a patient came into one of our offices and they filled out a PHQ-9 or the Columbia scale to assess suicidal ideation and suicidality, they would do that themselves and fill it out on a tablet in the waiting room or before they came in. And so now we've been looking at different ways to integrate that, everything from integrating it into a HIPAA compliant email that they receive before and they go to a link and they fill it out, to filling it out on the screen when they meet with the clinician. And we are piloting with integrating some apps into a few of our clinical pathways as well. But that's just kind of big picture. I think the most common one that we're using is just kind of exactly what we're doing today, but in the context of clinical engagement. And we also utilize, I should say, a step care models to determine when a patient needs higher acuity care, when they need to go into the office, into an inpatient setting, or when they need something like labs. You know, an example would be treating somebody for substance use disorder with medication-assisted treatment. We still do urine screens, things like that, to ensure quality and adherence to the treatment protocol. And so there's still, for us, very much a hybrid, and that is also because we also work with higher acuity patient populations, and so that for us still requires a hybrid of both virtual and in-person.
And Colby, if we have time, I might just jump in. I agree, wonderful, everything Lauren said. We look at behavioral health as a huge spectrum, everywhere from I'm a little stressed out, to I have some mild dysthymia or depression, anxiety, to I have pretty significant something like this, to organic disease, to all the way to inpatient care. And you know, we can do some of those things. We can't do all of those things. Substance use disorder, of course, is in there as well. But we've looked at a lot of vendors, and you know, there are vendors who will have allow for asynchronous chatting back and forth with a therapist. That's probably best for that lowest acuity group, the one that's just stressed or going through some adjustment. Synchronous therapy, synchronous psychiatry, you know, and even considering adding, we've looked at adding asynchronous in between visits to address, well, you know, you were having a good day when we spoke, but now you're in crisis 2 days later. You know, so there's all different ways we've explored and tried collaborative care with primary care offices. That's a wonderful model, but it's logistically very challenging. But maybe there's a way forward there, because we just don't have enough psychiatrists to care for all the patients who need their care. So many different varieties of needs and so many different technologies that can address those needs. Hopefully this will all consolidate out. In fact, our goal is to be able to offer the spectrum and to be able to triage patients into the right modality in the future.
If I could just add something super quick too, I think when we talk about behavioral health, one of the things that we have heard from almost every single ASHP member is the ability to address the issue of behavioral and mental health stigma associated with receiving care. They have had so many examples of patients feeling like they can actually go receive that type of care simply because it's now virtual. And so I think that is ultimately such an important argument when it comes to how do we get this to be permanent and for accessible for everybody, because we really need to do whatever we can in order to reduce that stigma. I think that's really essential.
Great.
Absolutely. And I want to go ahead and thank our panelists here for a wonderful conversation here. I think we got a lot more context as to where we are in terms of telehealth and COVID, and also a lot more context as to where, not only where we are going, but where we need to go in terms of telehealth post-COVID.